Morning, I'm Marty Cady, Managing Editor for Policy at Politico. I'd like to thank you all for joining us this morning as we kick off our Pro-Healthcare Report series with today's event, The Next Generation of Drugs, Policies and Regulations. Thanks, as always, to everyone joining us on the live stream. We're very excited to be hosting this event at such an important time in healthcare policy. And thank you for joining us on such a busy news day in Washington. Today's the rollout for the ACA, open enrollment, and the government is shut down. So it's an exciting day in Washington. We're glad you're here. We have a dynamic group today joining us this morning. Our panel includes Congresswoman Anna Eshoo, Democrat from California, Russell Teagarden, the Senior Vice President for the National Organization for Rare Disorders, Gillian Woollett, who is the Senior Vice President for Avalier Health. Congressman Phil Gingrey had to cancel on us and won't be making it today, even though he might be listed on your program. Before we get started here on stage, I'd like to thank PhRMA, the Pharmaceutical Research and Manufacturers of America, for their partnership on this series. Here to say a few words from PhRMA is our CEO, John Castellani. John?
Thank you, Marty. Thank you, Marty, and again, good morning. I think the Congresswoman wins the prize for the person who went to bed the latest or the earliest this morning, but it has been a long night and lots of exciting things that are happening today, so thank you again for being here. As I think you all know, the biopharmaceutical research industry, our scientists, the doctors, and the patients, all of us, are working diligently to make modern medicines by researching and developing new cures and treatments for a very, very simple reason. That is, we all exist to help patients live longer, healthier, and better lives. That's the purpose of our industry, and that's why biopharmaceutical research companies exist, to make that end a reality. Actual research and development, however, is a very complicated and a time-consuming task. It takes a lot of investment, and it takes a lot of time and dedication. It takes very highly trained and imaginative women and men, and it requires facilities and investment all over the world and all over the United States. It also needs great ideas and bold actions to realize those ideas. And it takes funding and a commitment for that funding over a long period of time, both to start the projects of research and to see them through. But one of the things that it takes that we don't talk about much is it requires a scientific, business, and economic investment ecosystem that really helps promote research as well as reward the investment and support the infrastructure that is needed to take an idea from the lab bench to the patients and get to those patients the medicines that will improve their lives. And this means it also needs public policy makers who grasp the complexity of the research process, who understand the rhythm of innovation and the possibilities of this technology, and public policy makers who are willing to support and promote policies that foster innovation, as well as a predictable, transparent, and science-based regulatory environment that's necessary to develop, review, and approve new medicines. Policy matters, and it has a profound effect on the research and development that we can do today, as well as what's needed in the future. And too often we hear about our healthcare system as if it was many disparate parts that seem to operate independently from each other. But in fact, what it is an integrated system that requires a cohesiveness and a coordination across the entire system if it's going to be able to function to bring long-term, healthy, cost-effective solutions to meet patient needs. So what we're here today to talk about is an understanding and a better understanding of how the economic policy and the reimbursement policy affects the research and development model. Policies that we're discussing here today really matter, not just for what's going on today, but what's going on in laboratories that is going to come to fruition in 10 or 15 years, the time frame that it takes to take a medicine from the laboratory bench to the patients. And that is where the policies affect whether or not the big ideas that come from those scientists can get to the patients. Whether it's in our industry, whether it's in a university, research center, whether it's in a hospital, or whether it's in the government systems, all of that is affected by how the policies drive the ability to train scientists, the ability to invest in research and development, the ability to review and approve medicine, the ability to bring medicines to patients, and the ability of patients to be able to afford those innovative medicines. So again, let me thank you all for being here. I know it's going to be an interesting discussion, and with that, I'll turn it back to Marty to introduce today's panelists. Thank you, Marty.
Thank you. John and Pharma, thank you so much for your partnership in this series and making today's events possible. Just a few housekeeping notes before we get started with the panel. Please make sure your cell phones are on mute, and don't forget to tweet your questions to hashtag #ProHCRReport. That's hashtag #ProHCRReport. I can already see that some people are using that, so that's totally cool, including front row here. Our moderator will be tracking Twitter and your questions from a tablet up here on stage. Now, without further delay, I'd like to welcome Politico Pro healthcare reporter Brett Norman and the rest of our panel to the stage.
People thought that before and found that differently, didn't they?
So, good morning, everybody. Isn't it nice to get a break from the news so we can sit down and catch a breath and have a good, long drug development conversation? Just a few minutes ago, we're going to get to that very soon, but we're a healthcare bunch, and it's the opening day of the exchanges. A few minutes ago, the websites went live, at least on the East Coast. They should be going. California is one of the most sort of early enthusiastic adopters. They've stood up their exchange and seem to be in as good a situation as anybody in the country to make this work. What are you expecting today?
Well, today is good morning, everyone. It's nice to see all of you, and it was a late night last night, so. But the coffee was wonderful. I'm wide awake, and I'm delighted to be here with the other guests on the panel. This is the opening day for enrollment, and I often say to constituents that we love our history once it's been made, but when we're making it, we go through an awful lot of gyration. So history is being launched today. This is an almost 100-year effort in our country, and as you said, California is in the forefront. Very important because California is a nation state. It's highly diverse, so it's a highly mixed population. We have a high percentage of individuals that have no insurance whatsoever. We have a gifted and talented Secretary of Health and Human Services, Diana Dooley, who has done a superb job in preparing for this. Now, there's no doubt that there will be glitches, but we were together before a medical group at Stanford University just about a week ago in my district, and she gave a very fine presentation there about all the nuts and bolts. So if California works, and I think that it will, then the other major states, New York, Texas, cannot say, we can't do this, that it won't work. So it is historic, it's experimental in many ways, but I also think very practically that for those of us that have health insurance, the very first day of enrollment is not when we make our decisions. So even though everyone is going to be waiting to see how many enrolled today, it's usually toward the end of the enrollment period. At least that's been my experience as a federal employee. So I'm very excited about it. I'm proud of it. And obviously, it's been a battle.
Do you have a sense of when we might get the first good idea of whether it is starting to work? I mean, Probably not in the first week. We understand it's going to be a gradual process of
Well, I
signing
think
folks up. But in 3 months and 6 months?
I think the big date is January 1st.
Okay.
This is opening day, but how many will actually be enrolled and actually receiving, having the insurance, and then being covered by it is really, I think, the most important date. So it's very important that there be a mix. I know that in California, the secretary was telling me that there is a great outreach to mothers. Mothers always, I'm not saying fathers don't, but mothers are dogged about keeping after their children to do this and that. And so I think that, the mix is going to be very important because that's what you need for a successful insurance pool.
And of course, the other big piece of news is the government has shut down. You were voting until 1:30 in the morning, I think you said.
1:32.
1:32.
To be exact, we want to be precise.
So, that's obviously a massively complex issue, but from the prism of the ACA, Secretary Sebelius has said that most of the funding is mandatory, most of the staff will be deemed needed, and we'll continue working to roll it out. But still, about half of their 78,000 employees are going to be furloughed, I guess, by lunchtime, and that's got to have an impact. You would think at some point. What do you think the shutdown? What's the effect the shutdown might have on the rollout of the ACA?
Well, first of all, I think it's a very sad time for the people of our country. I mean, we're the greatest nation in the world, the envy of the world. The confidence of the American people in their national legislature, those that are governed, there has to be a linkage with those that do the governing. And so this is enormously sad and unnecessary. That's what makes it even sadder. It depends on how long the government is closed. If, God willing, it's only a handful of days, then the toll and the damage will not be as great. But the longer it goes, the effect deepens and reaches deeper into the agencies and the work that people do. But there already is a layer of damage, and that's sequestration. I mean, if you just look at NIH and FDA, both representing so much of the future of our country. I mean, I come from represent the district that is really the innovation capital of our country and the world. And we're the envy, again. Not at this moment, I don't think, because it really is taking a toll. So, of course, it's going to have an effect. And it takes time to start back up again, too. I mean, this is not like putting a cup in a microwave and getting the water to boil in 60 seconds or less. So I think it's enormously sad, and I hope that this will be resolved sooner rather than later. And of course, when I got home, I don't know why I turned the TV on at about 10 to 2, but I did. And they were already on, mark it on your calendar, October 17th. That's, you know what date that is. So we're in a riptide of waters right now. And the sooner we resolve this, the better off the American people will be. But the agencies, there's no question about this, the agencies that carry out and implement what the Congress has set forward at the FDA, at NIH. NIH is all about investment. I always say to my constituents that I believe that NIH stands for our National Institutes of Hope. And if you have a disease, you want an investment in that for research because your life or the life of your child or your spouse or whomever it is in your family depends on that. That's how important it is. But we also give hope to the world with our breakthroughs because we are the leaders in that. And of course, at the FDA, there are critical investments that are made by the private sector. We just completed, not all that long ago, and approved and passed, the President signed into law, PDUFA, which is a bunch of letters, but what it means is that there's a partnership with the pharmaceutical industry. They willingly pay more fees in order to advance their applications. Those are private dollars, and sequestration does not allow the use of those fees toward what they do.
And we'll definitely get to PDUFA.
So,
I'd like to ask you about another piece of legislation that you wouldn't have known happened reading the headlines over this weekend, but last fall we first saw kind of a trickle and then a stream of fungal meningitis cases.
Yes.
And public health officials traced it back to contaminated steroid injections from the New England Compounding Center.
Yes.
There were big investigations in both houses, several hearings, and earlier in September, both the House and Senate hammered out a bicameral deal, and the House passed it this weekend.
We just passed it.
Yeah. Can you tell us a little bit about what the problem was with FDA oversight of this industry that had been kind of growing up, and what the bill does to address it?
Well, first of all, it was a huge tragedy. There are many people that died as a result of it, and there are many more that are struggling because of what was injected into their bodies. I have a very dear friend, lifelong friend, that has been hospitalized multiple times, and she has survived it. But this is really frightening.
I think 60 people died and 450
yes.
or so.
FDA and its lawyers have said that they did not have the authority to, to oversee the compounders. Now, there's a difference between the small pharmacist and what they compound. This outfit in Massachusetts actually became a manufacturer, and they were supposed to be inspected by the state. So obviously Congress had to respond, and we did. Now, there's a debate on the part of some on my side of the aisle that the legislation was not strong enough, that it didn't mandate that the FDA have this authority, but rather that they opt in. I do think that market forces will have an effect here. Because if anyone is going to be purchasing from one of these large manufacturers that compound, they're going to be very careful about who they do business with. And so Congress responded. We had to. It was urgent that we did. This does not affect the small pharmacies, but rather, the larger outfits. And when the facts came out about what was there, they could see the funguses growing. There were dead rats in the place, and we all depend on. These are things we can't do for ourselves. We're dependent on a framework, a structure, protocols to protect the well-being of people. And you see, when it's not there, what can happen. So I'm pleased that the bill passed, and I think it's well structured. As I said, there was some disappointment on the part of some members that they viewed it as not being strong enough. But again, I think anyone that is going to do business with someone that does this on a very large scale, they will look to see whether they have opted in, and that the FDA obviously has authority to inspect.
One last point on that.
Sure.
So the Society of Health System Pharmacists, the kind of health system-based pharmacists that compound a lot of stuff, and the community pharmacists back the bill. But the big compounding association, the International Academy of Compounding Pharmacists, is opposing it. Do you expect quick Senate action? Do you think they may have an effect in changing the bill before the Senate takes it up?
Well, as my mother used to say, we'll see. I mean, there's always, no matter what is passed, there's always room for improvement. But I think that each body, both the Senate and the House, members know that this absolutely has to be addressed. Members sometimes, well, I shouldn't say exaggerate, but I will. This is so important, this has to be passed, and some will even say it's life or death. This really is life or death. So, and a price has been paid by families across the country. I mean, it was really horrific. So I don't know if there will be changes. Maybe we can do another forum and talk about them if they are made. But I think the House came together on this in a very reasonable and important way, and I think the country will be better off when the authorities are very clear about who is responsible for what can be done, what is not allowed.
So let me bring the other panelists in. I want to talk a bit about biosimilars. It's going to be a huge issue coming up. It's already a $90 billion global market. For anyone who doesn't know, these are complex protein-based drugs that are often derived from living systems. These are not your parents' basic chemical compound. They're drugs like Provenge for prostate cancer, Humira for arthritis, and they're extremely expensive. They run $37,000 a year for Herceptin and more than $100,000 a year for others. So it's driving the drug spend already. And there's a huge incentive to try and bring those costs under control. The Affordable Care Act called for a new regulatory pathway at the FDA to help bring generic-like versions of these drugs to the market. And they've brought out a few guidances in these past 3+ years to give developers some idea about what they expect. But am I right that there hasn't been an application yet?
Right.
So,
as far as we know.
Yeah. So what's the holdup?
Well, there's a couple of things I think that are important to comment on. One, like with the compounding, quality is really, really important. So all of these products will go through the very same FDA that the originators have gone through. There is no compromise in quality. There's no compromise in the safety, purity, potency of these products. However, clearly, there's some caution and there's some care, but we're learning a lot also from the other highly regulated markets where a number of these products are successful. So I think FDA is being careful, but nobody has to wait on the guidance. I think there's a number of provisions in BPCIA that are raising questions and are unclear. Only one of them is sort of the lack of regulatory clarity. I think there's some confusion over exactly what the IP provisions, which are 80% of the statutory language, are going to involve. And then also there's a certain, what are we going to pursue in which market? Can we gain experience in other markets first, simply because the patents have expired there first? So I think everything's moving. I think FDA does know what it's doing. FDA is absolutely ready. They were ready the day the statute was enacted to review and approve these products. And we don't have industry on this panel, but it's a case of who applies first.
That's right.
And then FDA can make the decisions.
May I just jump in?
Yep.
I wrote the legislation together with Senator Kennedy. So it's very exciting. And the issue of patents is very important because as patents expire, then there will be continual movement on this. But it is, for those of you, it is a complex area. And for those of you that may not be familiar with it, what Senator Kennedy and I saw was an enormous opportunity. And we fashioned the legislation to essentially bring about a Waxman reform, which was passed for pharmaceutical drugs, and bring about a pathway for biologics. But biologics are not identical, and that's why they're called biosimilar. They're living organisms rather than what's compounded. So I think it's very exciting, and I think we took a huge step forward on this to bring the price down, because the debate in Congress, now this was bicameral, it was bipartisan, it passed the Energy and Commerce Committee 47-11, was rolled into the Affordable Care Act, passed on a bipartisan basis in the Senate Help Committee, and then went to the floor there. So I think it really represents the future, but you want people to have access to these life-saving biosimilars, but there simply was not a pathway for it. So now the path is opening up, and I think it's very exciting and very important.
So there are some already on the market, right, in Europe? Mm-hmm. Mm-hmm. What's been the experience there so far? Have they
They're actually around the world, there's a number of them, and I want to make the distinction that those products that aren't compared head-to-head are not biosimilars. This is a very high regulatory standard, and the European approach is very much akin to what the US is adopting, and based already on our approach to manufacturing changes in the US. So Europe has, I believe it's 17 on the market. They've just approved the first monoclonal antibodies as biosimilars. Those aren't launched yet. The experience is that it takes familiarity with the physicians to then use the products. There have been no unusual or unexpected adverse events with any of the biosimilars marketed in Europe. So I think they're very successful. And for certain products, they are now the leading product by volume in certain of the bigger European countries. So it's taken a little while to get the pickup and the familiarity. They appear to be taking off. They're very successful. And then those same products are also approved in multiple other countries, albeit not necessarily as biosimilars, because they haven't been developed head-to-head with a local comparator. So I think one of the questions for the US is, of those products that are already very high quality, very successful in Europe, what sort of additional clinical studies do they need to do to access the US market? And that's where the FDA is currently working with sponsors.
Okay. And so, like we said, it's a huge market, and it's really one of the very bright spots in in the pharma space now, kind of after the patent cliff. Earlier this year, we saw an effort by some companies to get some laws passed at the state level that have to do with different sort of notification requirements that touch on exactly that issue you mentioned, which is that biosimilars are not generics. They're not necessarily interchangeable, and should the pharmacist have to check with the doctor before substitutes a biosimilar for the more expensive biologic, and all of those sorts of notification type issues. Do you feel like these laws are premature? That's been one of the criticisms, because there aren't any on the market yet, and there won't be probably for a couple years.
So one just clarification, the real bright spot is the promise of biotech and the new products that are coming through. The biosimilars are simply going to be hopefully substantially cheaper versions of products we've already got. Mm-hmm. So let's not forget the real stimulus to innovation through the competition is those brand new ones. And pharma has a survey, over 900 biotech products are in clinical development. Those are the ones that are the real bright spot. But then of the biosimilars, the FDA uniquely in the US, by Congresswoman Eshoo's bill, has the authority to designate a biosimilar as interchangeable. Mm-hmm. Those are the ones that are subject to debate, and that's where the state laws come in. However, less than 1% of biologics actually go through the pharmacy. So it's a debate On various issues, it probably is premature. It's a debate about how some of these products are designated and the naming. But again, I think we have to be very, very careful. Fundamentally, a biosimilar is a biologic, and it needs to be subject to all the same standards, requirements, expectations. FDA is the only one that sees the data, and if FDA designates them as interchangeable, I'm absolutely confident the pharmacist can do the substitution in exactly the same way as done for a generic drug. But we don't expect any of those interchangeable biosimilars, I think, unfortunately, very soon.
But I do think that between patient, doctor, and pharmacist, that everyone should be in the loop.
And to know what's
very
being prescribed.
practically speaking, and that's what is at hand with pending legislation in some states. Certainly in the state of California, there's a bill that Governor Brown is considering right now, which covers exactly the issue that you just raised. Mm-hmm.
So let's change gears a little bit and talk about another space. It's a little less glamorous and maybe less profitable, but really important from a health standpoint. That's the development of antibiotics. And there's been a growing kind of plague of antibiotic-resistant bacteria that are a major problem in hospital-acquired infections. CDC released a first-of-its-kind report last month that sort of flagged the issue. There are some groups like Pew and others that are calling for Congress to take a closer look on this, and at least require the FDA to begin collecting some more information, in particular about the widespread use in livestock. But you, I believe you and Representative Gingrey had sponsored the GAIN Act to give, because this is not a particularly profitable space, right? Is that right? To give extra exclusivity to
5 years.
5 years to companies that develop new antibiotics that will help out with some of these organisms. Can you tell? And that was part of the user fee bill passed summer 2012. Can you tell us what has happened since then? Who's taken advantage of that, or have we seen much as a result?
Well, I don't think I can. Perhaps others on the panel can add to this, but we put it in place. So you have to look to who is filling the space and taking advantage of the period of exclusivity. That's always the carrot, so to speak, because companies really do need to be able to recoup their investment. Otherwise, they simply are not going to be interested in fill in the blank. The same with biologics and biosimilars. And that was really where the battle in the Congress was with those that were opposed to it. They said you're disallowing people from getting the cure. Well, they're not going to have anything if it's one of two things. If they have exclusivity for infinity, or they're able to recoup what they invest and therefore create, the kind of movement that you want in innovation, access to this for people. So that it was the sweetener, and previous to the effort, there wasn't anyone. Obviously, there was a shortage. We had a problem in the country. There are more people that say to me, no matter what, I don't want to go to the hospital because I'm afraid I'm not going to leave. Not because there's poor care, but because of nursing care and all of that, but because of these, the infection rates and what we sought to correct in this. So it's there for companies to take advantage of. And what the statistics are, it hasn't been on the books all that long. Maybe someone else has the numbers, but I'm very pleased that we did what we did. It's important. Again, these are things that people cannot do for themselves. So there's a clear role for us.
Let me swing back real quick, because Russell, I wanted to bring you in. You're a trained pharmacist.
I am.
Right? And some of the debate, like the congressman was saying, is keeping the pharmacist, the doctor, the patient in the loop with biologics. How important do you feel that is? I mean, how important is it that the pharmacist be the kind of an intermediary who sort of knows all the ins and outs of the differences between the drugs, is duly notified by the physician and can kind of communicate that to the patient?
Well, I think it's fair that the pharmacists be able to depend on FDA, like Gillian suggests, that if they say that it's interchangeable, then that they can proceed accordingly. And we'll have to get to that agreement. It sounds like we're heading there. But short of that, things can go wrong that in the course of therapy for a lot of different reasons, and any treating physician has to come up with what those reasons are and has to have the information to make that decision. And so it's reasonable that if a change has been made to a drug selection or a therapeutic approach at the pharmacy level that's permitted by, say, standards of practice, that be communicated to the physician so that, and the patient, should, if anything does go wrong, there can at least be on the list to consider. So a lot of that is just good practice. But good practice is also, referring to the frameworks that are in place that aid that practice. So it depends on where you're at there.
But I think fundamentally, we need complete records on every product and every patient, essentially real time. That's how you're going to optimize care, and that's for every product. It's not uniquely for biosimilars. It's for biologics, biosimilars, drugs.
We need less fragmentation, not more. And so completing that communication loop, whether it's electronic and there, or whether it has to be, the more clunky, hey doc, I made this change. That connection needs to be made.
And I know I've heard John Castellani talk about the mining of big data for the ability to do studies if you have this kind of vast trove of information. How far along are our health records? How reliable a source are they at this point for watching the safety issues, possibly doing kind of prospective trials, things like that?
I think everybody would say not far enough, but let's just pretend that even we get to the place where we're well connected in their standardization. That'll go a long ways towards helping us dig into for research, et cetera. But it's also going to be dependent on how willing the clinicians are to provide the information in those media. You can have it all set up, but if there's any reason to be reluctant or rushed or whatever, not to put in the information that's available, then we have a problem. So it's just not enough to set it there. We've got to establish incentives and standards to make sure that all the information's in there that we can use for those purposes.
I think what's very important in this, and it's not something that people have a drink and conversation over, is that throughout the medical profession, healthcare, that high technology really plays a huge role in this. And you have to have the broadband and the width of the broadband and spectrum to support all of this. I remember when Julius Janikowski came on as the chairman of the FCC, and I invited him to come to my district. The first place I took him to was Lucille Packard Children's Hospital. And we went into the operating room where there were at least, 7, 9 doctors operating on this little one. But one very large wall was all computer equipment. And so the doctors were communicating with even the researchers that were giving direction on the information that they had that they could apply right there as they were operating. So these issues are not separate from one another. So I think that we're making very important progress in the country. We still have a ways to go, but this is a very important element in terms of being able to capture the data and apply it in some of those very unique and critical settings.
Let's go back to antibiotics for one more minute. So the GAIN Act put new incentives in place, and kind of beginning to see a response to that. Are you hearing any calls for the need for any kind of additional action? Like I mentioned, there are some folks who are worried about the widespread use and routine use in livestock as contributing to the development of these
I haven't, I mean, to answer your question directly, but I also have learned that legislation, once it becomes law, has to mature. And so, the application of it and the growth in this area, it reminds me of an effort that Congressman Mike Rogers and myself authored, and it was to create the pharmaceuticals that were needed so that we would have, God forbid, if there was a biochemical attack any place in our country. We were not prepared for that. And so we established legislation, it was passed, it became law, and so that effort continues to mature and bring about the changes that need to be made in order to have the kind of supply if, as I said, God forbid, there were that kind of an attack in our country. And I think it's the same with the GAIN Act. I think it's the same with the GAIN Act. But I'm going to go back and check because I don't know. No one has come to me and said, this isn't working, or these are the kinks in the legislation and we need follow-up. As members say, I'll get back to you.
The other thing worth bearing in mind, infectious disease is the epitome of a global issue.
Yeah.
So also the other side is there's so many things the US can do, but we also have to recognize pandemics and infectious disease are coming from ex-US. And so that's an important consideration that some of the global infrastructure in WHO, there are other bodies that have a very, very important part to play.
So I want to talk a little bit generally about a challenge, which is to kind of encourage, and it's similar maybe to the antibiotic question, but to encourage research in areas where it's not done as often. This is something that, Russell, you're certainly involved with the National Organization for Rare Disorders, and to a lesser extent, you've worked on encouragement of using, studying off-label uses of prescription drugs for children, possible applications for children, right? Russell, can you talk a little bit about what was, Diane Dorman, I remember, said that the provisions in the user-fee bill last year were the biggest step forward for rare disorders since the Orphan Drug Act of 1983. Can you talk a little bit about what was in there to encourage that space?
Well, it focuses on, it makes some recognition of the newer science, the molecular biology, some other ways of characterizing diseases that facilitate defining targets and moving towards cures and so forth. So it's recognizing advances in science, advances in various scientific tools. It also recognizes that there can be certain disease processes that take so long to fully manifest in their clinical outcomes that there can be a need or a reason to look at certain surrogates. Now, we've done that forever, but in these other types of surrogates that are based more on molecular biology and so forth, to use to understand whether a particular therapeutic can be effective or not. And so it recognizes that in asking or having FDA be able to develop guidances and mechanisms to accommodate that new science and tools into the approval process. It's going to be a process. We're going to work through it. We're working with various communities to decide just what that is, because it's very difficult. But the idea is it will make more therapeutics available more quickly, which is what the end game is.
So should we, we're only 1 year into PDUFA 5, but it's not really all that long until people will start negotiating PDUFA 6. Are you guys looking forward yet to that, or is that still kind of sometime in the future? Are there kind of big issues we should be keeping an eye on, you foresee being kind of a central focus in PDUFA 6?
Well, if I might, we have a huge issue right now, because this is, I think, really one of the more remarkable public-private partnerships between industry and a key government agency, the FDA. So we should all appreciate that. And this has worked very, very well over the entire life of PDUFA in all of its iterations. Now, in this last go-around, the industry voluntarily increased what they would pay in terms of user fees. Now, of course, there's an interest on the part of the industry to do that, because it funds the personnel to move the applications. That's in the interest of the American people. It's in the interest of the industry, and that's why I say appreciate this, that this is really a remarkable public-private partnership. But something came along after this was passed: sequestration. Now, regardless of what you think of sequestration, I think it's just idiotic. It's stupid. This is not the way to do business. This is not the way to budget. Nonetheless, it's there. These private, sequestration was relative to public dollars. These are private dollars. And so FDA, there's a huge cloud hanging over the FDA right now. And after all of the negotiations that took place, these were tough negotiations on many, many issues this year. So before we look way down the road, or number 6, or the next negotiation, or whatever, we have a big problem right now. Now, I authored bipartisan legislation. It's gathered excellent support that FDA that sequestration would not apply to the FDA in this area. Now, I've written to Treasury. Given the shutdown last night, I don't know who's going to get back to me when. I want to know where this money is. Is it being held in some savings account? Where is it? And we also have the U.S. Patent Office that runs completely on user fees. Now, these are areas, keep in mind, that are the areas of innovation for the United States of America. So this is, I would say that we have a huge problem right now. This needs to be resolved, and I hope that sensible people can come together, and if sequestration is to stay in place, this must be addressed. It really has to be addressed.
So Congress did intervene to address the issues with the FAA, right, and the sequestration. Is there any appetite for it? I mean, like you say, it's not quite the same public resonance.
It is bipartisan. If there were only Democrats on it, I would say there would be next to no hope. But if Republicans are willing to sign on to this, and they have, we'll see. We need to get this going in the Senate as well. And really, at the end of the day, I think if you went member by member, they would say, we don't want the outcomes that this will produce, the sequestration and FDA and all that it represents. And I mean, it just cuts off the work that we did. You can be celebratory on the one hand, and then on the other hand, It's just the door is slammed shut, it's locked, these dollars cannot be applied. This is not good, it's not right, it needs to be fixed. So I'm going to keep pushing on it because I think it's an essential.
And I do, in the biologic space, looking ahead, do you feel like it's going to mostly be an evolution in the private sector? Is there anything at the federal level, in addition to clarifying the biosimilars, clarifying the guidance that needs to be done?
I think it's going to be interesting to watch because you mentioned PDUFA. We also have MDUFA devices, BZUFA for biosimilars, and GDUFA for generic drugs. So we have 4 user fee programs. We've had 5 PDUFAs, 3 MDUFAs. There's a level at which maybe collectively we need to look at how user fees are applied to the agency. Now, there was a unique aspect to the biosimilar one, which was to pay pre-approval for meetings with the agency. And again, it's a resource question. You've paid the user fee, the agency needs the resource to provide the service. So I think there is a collectively looking at what we're expecting user fees to pay for and what the industry is getting. And fundamentally, a biosimilar, because it's just a biologic, there's a lot of front loading in terms of all the analytics. It's not going to be an easy job for the FDA to do these reviews. There's a lot of work. I think the FDA knows what they need to do and knows how to do it. They coordinate very closely with the other highly regulated markets. We've had the International Committee on Harmonization for donkey's years. So there's a lot of experience. The question is, I think, how some of the other aspects of the legislation are or are not constraining. And I would say the IP provisions are one. And then if this pathway doesn't appear to succeed, I think we have to look very, very seriously as to why not. But I think we've got a little bit of time before we make that judgment. But that Europe has now already approved monoclonal biosimilars, I think is telling us a lot. We'll be getting a lot of data from there, and then we can ask perhaps why what's happening in the US is happening in the US. But there's a lot of meetings going on. There just haven't been any actual filings yet.
All right, well, it's time to wrap up our conversation. Although before I do, I'd like to get one thing from you, briefly. What's your prediction on how long this shutdown's going to last?
I can only tell you what my fervent hope is, that it will be very, very brief, because this is, it's going to obviously take a toll on the country. This is not the best of us by any stretch of the imagination. And while this is damaging on many fronts, there's a spillover of this moving toward the debt ceiling as well, which is the equivalent of a nuclear weapon, I think, to our economy. It's been very difficult for us to come out of a near collapse of our national economy from 2008 forward. Everyone in some way, shape, or form has been affected in the country. Businesses, individuals, families, workers, you name it. It's taken a huge toll. And to think that, I think Politico had brinkmanship on the front page today, and that we would be on the brink of moving toward that. I just pray not. I just pray not. So I can't make predictions, but I was there. I was in the Congress in 1995. When I was walking to votes last night, there were 2. I don't know whether I think they were both freshmen, Republican members, and they asked me if I had experienced in Congress the 1995 shutdown, and I said, and they said, what was it like? And I said, well, we always debate in our country what the size of the government is, whether the people like it or not. But I said, let me tell you something. They're paying taxes. They want their services. It doesn't matter what part of the country it is, whether they're Democrats, Republicans, Independents, Tea Party, it matters not. Members are going to be hearing from their constituents, And I think they will understand, those that think that this is a grand idea, that there's a real blowback to this. So hopefully it will be brief and we can move on and deal with the 17th of October before the 17th of October.
All right. On that cheerful note, we will wrap the conversation. Thanks very much,
Thank
panelists,
you.
for joining.
Thank you. Thank you to everyone in the
Thank you again,
audience.
Pharma, for making this possible.
Yes, yeah.
Thanks to everybody for watching on the live stream and in the room, and we hope to see you at the next Politico Pro conversation. Thanks very much.
Thank you.